So I wanted to focus on anterior uveitis in this session. So we're going to talk about just idiopathic anterior acute anterior uveitis, which is what you're going to see most often. I'll talk about some HLA-B27 disease and the associated syndromes with that, and also just some syndromes that can cause anterior inflammation. And then in future sessions, we're also going to talk about things like JIA, for example, Behçet's, inflammatory conditions, and posterior segment uveitis and scleritis as well. But today's session will focus on these three things specifically. So, idiopathic acute anterior uveitis, up to about 50% of everything you're ever going to see will be this. It can happen in anyone. There's no predilection in terms of things like gender or age. And essentially, it's the most common thing you're going to see when it comes to intraocular inflammation. It's almost always unilateral, but it can be bilateral. And the typical features these patients are going to come across with pain, photophobia, and redness. Clinically, you're going to see some limbal injection, maybe some KPs, some flare, possibly some posterior synechia, depending on how bad the inflammation is. But this really is going to be the mainstay of what you see, especially when someone's coming in for their first episode. And when it comes to treating idiopathic acute anterior uveitis, the important thing is just to nip it in the bud. You really want to treat the inflammation hard and fast early, and avoid the complications of uveitis. So with the uveitis sort of consultants I've worked with in the past, their sort of general understanding is, or the general teaching it tends to be, treat it hard to begin with, and then take them off slow to avoid it coming back. So with steroids, start strong, give them hourly steroids, maybe for a week or two, and then start to taper them down. So hourly, then 2 hourly, then six, four, three, two, one. And usually the five is skipped just for the sake of just speeding things up when you're coming off the steroids. But it is the initial treatment of steroids that is going to actually treat the inflammation. It's not 7 weeks of steroids that treats uveitis. It's actually the first week or two. And usually when you're seeing them for their follow-up, their inflammation should really have settled quite considerably. And then the taper is about reducing the recurrence and taking them off the steroids slowly. And it's the same sort of concept of taking somebody off oral steroids slowly as well. But really, the treatment of AAU needs to happen quickly. Um, and the way you can give steroids is it's typically given topically. But if you're already seeing lots of posterior synechia, for example, the pupil is not being released immediately in front of you, you can give some subconjunctival bet, for example, to try and give some steroids very quickly. Or you can even consider even starting them on systemic steroids, depending on what you're looking at in front of you. But that's really quite rare when you've just got a simple AAU in front of you. And you also then want to dilate the patient, and this is about avoiding things like posterior synechia. So give them some cyclopentolate, usually for a week or two. Once the inflammation has settled, they don't need to be on that anymore. And remember to tell the patient that their vision may be even blurrier than it was when they first came in while they're taking these drops. Atropine for the more severe cases, or if cyclopentolate isn't opening things up. And like I said, if you've already tried to dilate the patient in front of you because you wanted to look at the posterior segment and they're not dilating very well, with the bet, if you just mix it with some midrocaine and you can just dilate them immediately with just some subconj bet and mid. And then there are severe cases where you're going to think about things like the systemic steroids, for example, or like I said, the subconj steroids or the subconj midrocaine when you've got them sat in front of you. Moving on to HLA-B27, this is a slightly different disease, and even though it may present very similarly to idiopathic uveitis and essentially treated the same, these patients need to be counseled a bit differently in that it can happen more often, it can recur more aggressively, and it tends to occur in younger patients and more commonly in males. There is more of a predilection when you are HLA-B27 positive. And actually, those with uveitis, so if somebody has uveitis, they're 5 times more likely to be HLA-B27 positive than the average population. So if you take everybody in the population, I think there's a um you're essentially, I think you're about 8 to 10% chances of being HLA-B27 positive, whereas those with uveitis are about 50% likely to be HLA-B27 positive. So you're much more likely to have HLA-B27 running around you if you are getting uveitis than the average population. The disease, like I said, can be more persistent, it can recur more often, and they're slightly more likely to have severe disease in terms of having fibrin in the AC or hypopians at presentation compared to just idiopathic AAU. Um, and there are lots of sort of, sorry, that should say seronegative, related inflammatory conditions. So You're thinking of things like angst-spawn, psoriatic arthritis, inflammatory bowel disease, and reactive arthritis. These are your sort of typical seronegative spondyloarthropathies. And up to a third of them will present with uveitis, and there's a strong association with HLA-B27. And the ones that I'm going to talk about are those four at the bottom. So angst-spawn, it's a chronic disease. It mainly affects your spine and sacroiliac joints. So 95% of these patients will be HLA-B27 positive, and up to a quarter of them can develop uveitis. So when you're seeing an AAU in front of you, sometimes AAU is the first way that these patients are presenting. So ask them about any back pain, any stiffness in their joints. And usually these patients will respond to just standard treatment of uveitis. So while they should be under a rheumatologist for their treatment of angst-spawn, there's usually nothing special that you need to be doing from a uveitis point of view, but they can progress to chronic uveitis where they're on long-term treatment. And systemic immunosuppression in these patients is usually quite helpful in actually reducing their recurrence of uveitis as well. So that systemic management is really important. So send these patients to a rheumatologist if you think they need it. Get that X-ray of the back, for example, if you think they need it as well. Psoriatic arthritis, this is less commonly associated with uveitis, but you know what psoriasis looks like. It's these salmon pink sort of rashes, usually on the extensor surfaces. So ask patients about a history of psoriasis. Do they have any rashes anywhere in the body? And again, usually with your seronegative spondyloarthropathies, they will respond to standard treatment. It's more a case of knowing, is there something underlying, in which case, is this a patient that I will refer? Typically with idiopathic uveitis, I don't typically refer them to a uveitis clinic. It can happen just the once. There's no promise that it will ever happen again. But if a patient has an underlying condition that I think is driving the uveitis, I think these patients are usually better off in a uveitis clinic for follow-up. Inflammatory bowel disease, it less commonly presents with uveitis, so only about 5% of these will develop it. And again, it responds to standard treatment. And the important thing with IBD is systemic management does often control the ocular manifestations. There is the unlucky bunch that even with good control of their IBD, they still respond quite heavily they still have quite severe uveitis. But typically managing the systemic disease will actually manage their intraocular inflammation as well. And lastly, reactive arthritis, you'll remember this from university. So you can't see, can't pee, can't climb a tree. These are usually related to STI infections or dysenteric infections of the bowel. And again, you need to treat the systemic condition for their uveitis to be treated. Don't leave that systemic condition alone and involve your physicians. And lastly, I wanted to just touch on some AAU syndromes. So these are a collection of syndromes that essentially usually present with anterior inflammation. And you need to consider them because the treatment can be very different and your focus of the treatment can be very different. And the way you distinguish them from idiopathic AAU will largely depend on what else you can see on the eye and the medical history of the patient. So starting with Fuchs heterochromic uveitis, 90% of these they're usually unilateral, very often unilateral. And the features of sort of Fuchs heterochromic uveitis is the heterochromia can kind of give you a tip. So you tend to have a lighter iris in the affected eye, and that's because of your sort of exposed uvea, which tends to be a bit more blue. So you'll get sort of stellate KPs all the way across the endothelium. You might get these iris nodules, potentially some vitreous floaters. They may have a cataract, posterior subcapsular. It's typically the kind of cataract that you get. And importantly, with Fuchs heterochromic uveitis, they also get an increased IOP with their inflammation. So you might find that these patients are coming in with a hypertensive uveitis. Now, in future sessions, I will go into sort of infective causes of uveitis, especially with your human herpes, and they tend to also drive a hypertensive uveitis. So it's an important differential to bear in mind. But just for the sake of this session, I'm just talking about your sort of non-infectious anterior uveitis syndromes. And interestingly, they also can sometimes get these very sort of like branch-like vessels in their angle. Now, that typically isn't necessarily clinically relevant, but for example, when you're doing surgery or if you're going to do an AC paracentesis, they can bleed because you can nick these vessels. So when you're doing cataract surgery, it's important to consider that that can happen. And the management of these patients, the inflammation is not typically the problem. It's more the pressure. So inflammation, if you have some mild inflammation and they're asymptomatic, you may not need to control it, but what you do need to control is the pressure of these patients and control their long-term pressure control. And with pressure, they can be very difficult. Obviously, you have an inflamed eye. These patients are going to be much harder to control from a glaucoma point of view. Trabeculectomies are more likely to fail on these sort of patients, so they may point towards more tube surgery. And there are some glaucoma sessions that I've done in the past that you can refer to in terms of from that point of view. And then in terms of cataract surgery, there are also considerations to be made. So these are patients that might be on steroids in the past. They may have, because of the uveitis, they'll have developed a cataract and they may need cataract surgery. But they're patients that are going to be prone to lots of inflammation and pressure rises afterwards. So these are patients that sometimes what you might find are sort of given prophylactic courses of steroids before the cataracts operation. So they're given topical steroid treatment before the operation itself. And after the operation, you may consider giving them more steroids, maybe some subconj dex before you finish off, and also consider pressure control in these patients afterwards because they can spike after cataract surgery as well. Posner Schlossman, lots of people have heard about this. It's very easy to sort of forget it. But these are patients that come in with very high IOPs despite minimal activity. So these are patients that are going to come in with pressures in the sort of 40 to 80 range. It will be very, very high. But they're not going to necessarily have a lot of AC activity, but they will have some. Um, and there's an understanding that there might be a viral underlying association, and the theories are in terms of what drives the pressure and the minimal activity is essentially a trabeculitis. So your trabecular meshwork is inflamed, your aqueous is not leaving the eye, therefore the pressure becomes very, very high, almost like a closed angle. But you get this minimal activity because that trabeculitis is releasing those cells. And they're going to come in with features essentially of a high pressure. So they're going to have blurred vision, maybe some halos, and a very high IOP with a relatively quiet eye. And the management of this is bifold. So you're going to treat the inflammation, and you're also going to treat the pressure, and you're going to wait for the episode of trabeculitis to settle down. And these are patients that may then require eventually long-term pressure control. And the inflammation is really important. So even though you're not seeing much in the way of steroids, you still need to treat them because the trabeculitis needs to settle down in order for the pressure to come down. Giving them pressure drops but not treating the inflammation, you're not going to win. Whereas Fuchs heterochromic is a bit different in that you may not need to treat the inflammation, but the pressure needs control. So it's important to try and distinguish between the two, or at least have both as differentials in the back of your mind. And anterior segment ischemia. So you shouldn't forget this as a potential cause because actually it's quite life-threatening. Anterior segment ischemia, I've spelled that wrong again. Essentially is it's an ischemic eye, and you're going to have significant flare. Now, flare is essentially it's different to cells because it's proteinous material that's been released in the anterior segment. And flare tends to actually sometimes be a bit more concerning because it suggests ischemic processes. You may see some new vessels at the iris, new vessels in the angle. You may see some evidence of posterior segment ischemia with NVE or NVD, and you need to understand what the underlying ischemic drive is. And sometimes, for example, ocular ischemic syndrome is a cause of this. So you need to treat the underlying cause of the ischemia, and you then also need to treat underlying systemic disease. So these are patients that may need cardiovascular risk stratification, control of their cholesterol, looking at their blood pressure, looking at their blood sugars, because the anterior segment ischemia could be being driven by a systemic disease. They could be, only a few moments away from a stroke if they have quite severe carotid stenosis. So are you going to send these patients off for ultrasound, for example? And especially when you have a very unilateral ischemic eye, that should really be raising red flags of ocular ischemic syndrome. Bilateral ischemic conditions are more typically things like your diabetics, for example, or hypertensives. But unilateral disease, think things like CRVO, but also ocular ischemic syndrome. Schwartz Matsuo syndrome is what you might find patients that come in with retinal detachment and associated inflammation. And these typically are associated with your sort of larger, broad, shallow retinal detachments because you've got lots of photoreceptors that have been ripped apart essentially because of your detachment of the neurosensory retina. And those photoreceptor outer segments are essentially floating around inside the eye. They block the trabecular meshwork. They cause a trabeculitis, and you'll get some sort of mild AC activity with a raised IOP. And the management is essentially managing the retinal detachment, but patients with retinal detachment can then end up with chronic inflammation and chronic pressure problems. So again, these are patients that you might find will then need chronic control under the glaucoma and uveitis clinics if they need it, with control of that trabeculitis and that pressure. And tubular interstitial nephritis, again, this is rare. It's associated with tubular interstitial nephritis, which itself is a rare disease, and uveitis isn't commonly associated with TIN either. But TIN itself is usually idiopathic and it can be drug related, but it tends to be idiopathic. And these are patients that are essentially going to present with uveitis and renal disease. And this is why you might find in some centers, anybody who comes in with uveitis will get a urine dip. And essentially what you're looking for in that urine dip is evidence of protein or blood, which may suggest that these patients need referral to a physician to check for their kidney function and to check for TIN. So you may want to think of sending off bloods, looking at the U&Es. Do they have a raised CRP and ESR? These are patients that may eventually get a renal biopsy where on histopathology you'll see this interstitial nephritis and you're going to treat them with systemic steroids. You'll treat the uveitis as you would idiopathic uveitis, but these are obviously patients that need systemic immunosuppression to control their interstitial nephritis under the care of a renal physician. And lastly, just some honorable mentions. IgA nephropathy, it's a common renal disease in children and young adults. Obviously, we say common renal disease. You need to have a renal disease for it to then be common. But they're going to have episodes of hematuria, and they can then be associated with uveitis. And lastly, Kawasaki's disease is an acute vasculitis. So in these children with uveitis, remember looking for these other um, uh, evidence of Kawasaki's disease. So, for example, your strawberry red tongue, your swollen feet, for example, and AAU is very common in the acute disease. So, if you're seeing these children present with these uveitis, remember to do a full systemic review of the child and make sure that they're not presenting with an evidence of an underlying vasculitis. So just in summary for this session, the majority of acute anterior non-infectious uveitis you're going to see is going to be idiopathic. Consider some underlying non-infectious associations, and in future sessions, we'll talk about the infectious associations of uveitis as well. And strong initial treatment is really key. So don't start these patients on your sort of QDS steroids for 4 weeks and then 3 times a day for 4 weeks, etc., etc., etc. If they have uveitis, treat it hard and treat it early and give them those steroids strong. The only thing to bear in mind with them is just remember to, you might want to bring these patients back in a couple of weeks for a pressure check or tell them to go to an optician for a pressure check if you're worried about that. Steroid responders are usually about 20% of the general population, but if they have a history of glaucoma, or if they have a history of a steroid response, just remember to also give those steroids hand in hand with pressure control. Pressure control tends to be, people tend to opt for something like a Cozopt. So, like a timolol plus a dorzolamide, and that tends to be because you want 2 drops to make sure that the pressure is well controlled. And people tend to try to avoid prostaglandin analogs in uveitis because a sort of prostaglandin analogs can cause uveitis or CMOs. They tend to try to be avoided in those, but they're not actually contraindicated in patients with uveitis. But you might want to consider using something like a timolol or like a beta blocker and a carbonyl anhydrase inhibitor. But that key message of just treat the uveitis strong and then taper them off to try to avoid the recurrence. And that's how you should be thinking about your steroid taper, which is why starting somebody on QDS is probably not quite going to cut it. That first week or 2 is really where you want to be treating that uveitis. So that brings us to the end of this specific session. Please do remember to fill out the feedback, especially if you're just watching online. Do just click that link in the description, and then there'll be future sessions on infectious associations and also like your sort of posterior segment uveitis and scleritis as well. So I'll end the session there.